We've just had a very, very nice practical workshop on the arterial switch operation, and of course this audience is quite experienced and does not really need very much in the way of technical information to be passed along. I will try to cover some highlights of the technique, review very briefly the relatively recently published transposition guidelines, and also cover the European results. As we all know, this operation was introduced in 1975 and first published in 1976 by J. Of interest is that he based this coronary transfer operation on cadaver studies, and the first child he did died. The second one was successful in an older child with transposition VSD, and that was the case that was published and made this famous. The subsequent 5 cases did not survive, but the arterial switch was here to stay. As we know, initially, when this was tried in patients with intact septum, it was uniformly fatal in very experienced hands in excellent centers in London. Eventually, it was realized that the problem was the low pressure left ventricle. The problem was addressed initially by the 2-stage switch, which was introduced by Magdi Yacoub and in 1977. But then really the arterial switch operation for patients with intact septum was popularized by Aldo Castañeda in the Boston group and then spread throughout the world. Regarding the technique, again, as I mentioned, it is pretty much standardized, and we've just had an extensive workshop on it. Everyone knows the essential steps of the operation involving identifying and taking the coronary buttons, transferring them to the pulmonary trunk with a variety of techniques. This is a typical trapdoor flap technique, but there are other options which are preferred. And then the Lecomte maneuver, the pulmonary anastomosis after the reconstruction of the neo-MPA and the completed operation. So this is just as a refresher of something which is very much standard in our practices. Now, this operation is standardized, but I think it remains technically challenging. Early on, the mortality was significant and related to experience. You'll notice that in centers in the early years that did less than 10 a year, the mortality was more than 50%. And in centers that were doing 40 to 50 a year, the mortality was down to about 10%. Now, it is important to keep in mind that this operation is very, very useful for a variety of lesions, although typically when we talk about it, we refer to the lesion of transposition intact septum or VSD, but it has, of course, many other applications. It has a great impact on pediatric cardiac surgery. So the lessons from this operation have been transferred to care of Al Kappa, the Roscoe operation in neonates, even in Norwood, when sometimes we transfer the neo-aorta as a coronary, and of course these other complex operations, not to mention the benefits to small body technology and ICU and nursing care. Now, even though the switch operation has become the standard operative technique for most patients with transposition, and it is performed widely with very good results and very low mortality. Nonetheless, there is a wide variability in management with several controversial issues, and there actually is a wide variability of results, which is why the congenital domain of the EACTS a few years ago, in cooperation with the AEPC, put together a panel, a task force, to review the literature and create evidence-based guidelines. And there were experts from 3 continents involved. This was the initiative of our late friend Juan Comas, who was then the chair of the Congenital Committee. And the work culminated in the simultaneous publication of the guidelines document in the European Journal of Cardiothoracic Surgery and in Cardiology in the Young, to reflect the cooperative effort of the surgeons and the cardiologists in producing this document. The methodology was to define specific issues of interest, review the literature, evaluate the strength of evidence, and create the guidelines looking at issues ranging from diagnosis to long-term complications. Now, this document excluded those various other forms of transposition to make it manageable, because there was already enough controversy and work on dealing only with intact septum transposition. There were more than 400 articles reviewed, and practice recommendations were formulated, and level of evidence and class of recommendation was assigned according to the very well-known rules. There were many topics examined, as you see here on the left, and in this presentation I will just summarize maybe 6 of the very many recommendations involved. The first one regarding timing, which has been discussed. I think the class 1B recommendation was that the primary switch should be done from the first few days to 3 weeks, and that it should be considered as a primary switch until 60 days of age with ECLS backup. Regarding the adequacy of the LV, ventricular septal alignment or left to right bulging on 2D echo was considered a good indicator for adequacy of the ventricle. The central issue, as we all know, and the technical challenge has been the coronaries, and I will not go too much into this, but just to note that all patterns are considered transferable, but obviously the abnormal coronary origin and root, especially posterior loops, was traditionally a risk factor for outcome. And here are the relevant recommendations. Again, although all coronary patterns are transferable, some require special surgical care. Large coronary buttons and mobilization of proximal coronaries is recommended. Posterior looping implantation should be high. Intramural course best to be addressed by unroofing and individual transfer if the ostia are very close by, if possible, and for dominantly AP vessel pattern, the Lecomte maneuver. Now, again, we've covered this very extensively at the workshop. Just diagrammatically, this would show how one would unroof and try to separate closely related ostia for a single coronary and modified Yacoub approach, which is, again, well known to everyone, would be useful. Occasionally, a coronary extension with a pericardial tube could be useful in non-facing sinuses. And a final note on side-by-side grade vessels. I think one has to be careful to shift the neo-MPA anastomosis to the side to avoid compression of the coronary anastomosis. Is there still a role for the atrial switch? Yes, class 2A recommendation for non-facing coronary origin for late referral as an alternative to two-stage repair in children or in developing countries with no setup for a switch, or for transposition with persistent pulmonary hypertension. As Professor Fragata mentioned in his talk during the workshop, to prevent right ventricular outflow tract obstruction, there should be care taken at the original operation. But if RVOTO should develop late, then intervention should be considered for a high gradient with surgical patch angioplasty as best option. Ballooning should be considered only for obstruction at the valvar level. For residual coronary lesions, again, this is an area of continued interest. If there are signs of ischemia, there should be a diagnostic workup and reoperation indicated when the diagnosis of ischemia is established and the lesion is documented, with a preferable surgical technique being patch angioplasty of the coronary ostium. Limitations of guideline documents should be always kept in mind. Guidelines are recommendations to help physicians make decisions, but they are not a substitute for clinical evaluation and judgment, with the ultimate specific decisions regarding the care of an individual patient being made by the responsible physician. Now, we've covered what we can do, so science can tell us what we can do. We've covered a little bit about guidelines, meaning what we should do, but registries tell us what we are actually doing. In other words, without data, you're just another person with an opinion. ECSA, the European Congenital Heart Surgeons Association, has developed, in close cooperation with our sister organization in the United States, a very robust and huge, actually, database containing information on now almost 280,000 congenital operations. And in this database, you see that actually the arterial switch operation is the 6th most common operation. Last I looked at this, the number had gone up even from what Jose Fragata presented in the morning, because data always accumulates. There's data on more than 7,000 arterial switch operations with a hospital mortality of about 5.5%. And note that it is really a very, very common operation. Now, if you look at the mortality trend over the years, it looks like in the year 2000, the mortality was in excess of 10%, 10 or more, and gradually it has come down and continues to be for the last several years at about 5%. This is an arterial switch operation for transposition intact septum. Now, if you look at the difference, you can see that the numbers for arterial switch intact septum, 5,000 operations, mortality 5%. If you look at the arterial switch VSD, the numbers here are a little lower because this analysis was done looking up to 2015, 1,700 operations, mortality 9%. So the difference is significant whether there is or there is no VSD. If you look at the difference, you see that if you look at transposition intact septum, the results remain the same. There has been a mortality decrement of about 1%, which is statistically significant because it's a huge number. I'm not sure it is clinically very significant. Probably would not be in a single center. Now, if you look at transposition VSD, the mortality still is around 9%, and there is no statistically significant difference. We've also looked at the major complications using the STS morbidity score, which takes into account the parameters shown here, including acute renal failure, AV block, circulatory support, and unplanned reoperations. And we see that, in fact, there is no difference in the two eras when we looked at intact septum, and no difference when we look at transposition VSD. So in summary, if we now say, so what are the results of the arterial switch operation in Europe? we can say very definitively that the switch operation is associated with lower hospital mortality and morbidity than the switch VSD operation, that hospital mortality after the arterial switch operation for intact septum has decreased between the two study periods, but not for switch VSD, and that arterial switch operation VSD has a higher frequency of postoperative complications. Future directions, we should continue to look at particularly the late complications and therefore think about ways to prevent them in the operations we're currently doing. EXA has recently published a nice study which I would recommend for you to take a look at on left-sided reoperations after the arterial switch operation. And we are currently launching a study of coronary lesions after the arterial switch operation in patients with transposition. Do we need interventional follow-up in asymptomatic patients in view of the fact that in many centers who have looked at coronaries very specifically, the finding is an incidence of 4 to 6% of even asymptomatic significant coronary lesions. So, in conclusion, the switch operation, the procedure of choice for transposition, is widely performed in Europe for most patients, has been refined over the years, and it is generally associated with very, very good results. Recently published guidelines provide evidence-based guidance for managing patients with transposition, especially regarding persistently controversial issues, and that significant early mortality and late morbidity and complications persist for many patients, leaving room for research-based suggested improvements. And along these lines, ongoing multi-institutional studies, such as those organized by EXA, will hopefully lead to new knowledge and improved outcomes. I thank you very much, and I take the opportunity to invite everyone to attend EXA's annual meeting, which will be held in June 2019 in Sofia, Bulgaria. And I should say that this meeting is being co-organized with the World Society for Pediatric and Congenital Heart Surgery, so we'll bring together the congenital surgical community from all over the world. And we'll also have very significant input thanks to EXA's collaboration of several years now with the Association for European Pediatric and Congenital Cardiology. I thank you very much.